So millions of people saw changes in their plans and pricing at the beginning of 2026. With the implementation of the 2025 reconciliation law, many states are cutting funding to Medicaid programs. States will soon begin implementing Medicaid policy changes that may increase the number of people without insurance by 7.5 million in 2034. Joining me now is Adamika Meadows Arthur, CEO of Health Tech for Medicaid. Welcome.
Well, hello. How are you?
I'm doing well, doing better than our policies right now, right?
Oh, yes. Well, I understand that deeply.
Right. Medicaid cuts are often discussed as a budget line item, but what do these cuts actually mean for Black families, especially, Black women who are both caregivers and healthcare workers all in the same?
Well, first, most people don't know what Medicaid is. So Medicaid is the largest insured population we have in this country. So it's an insurance plan. Let's just start there. So most people have heard of Medicare. Medicare, it's a federal program you get over the age of 65. Medicaid, you can have both, Medicaid and Medicare. Those are called dual eligible individuals. But Medicaid is never really called Medicaid. It's only called Medicaid in about 7 states. But it's in all 50 states and our territories. So it's done about 56 different ways in the country. And so, it could be called in Washington state, it's called Apple Care. In California, it's called Medi-Cal. So most people actually don't know that they are on Medicaid in some ways because it's a state and federal partnership. But they truly are on Medicaid. And that's part of the challenge there is that it's called something different in every state because it's a state and federal program. But when I think about, Black folks, Black women in particular, or others, many of us who are caregivers or who are healthcare workers, we're carrying the burden, kind of twice, and we're being paid less every time. These cuts for Black families mean a lot, right? Because if we're losing our health care or we think we have health care and we're going to the doctor and we get there and we don't have coverage, this means a lot for, medical debt, which is, the number one way that people lose their assets in this country. It also, leads to a lot around the unpaid care, people delaying going to medical treatment, why people are leaving the workforce the way that they are. So, there's a lot kind of there around just this budget line item around Medicaid cuts. It means a lot for Black families. Over 50% of the births in this country are Medicaid births. Many of those are Black families. There's over 40 million Black people on Medicaid, and much of them, 50% of those are children. So most of our kids and our elderly, get their care covered by Medicaid. So if it's not just us, it's our, it's our cousins, our parents, our neighbors, our friends. It means quite a bit to our communities.
And so what does it mean when they're talking about defunding then, something that has that much weight? What happens when we destabilize both in the workforce and in the insurance coverage that Medicaid provides?
Yeah, it's a double whammy, right? We are overrepresented in Medicaid as Black people. In some ways, that's a good thing when you think about how Medicaid was actually started. It's a beautiful story. Medicaid was started, it's 60 years old. It started in 1965. Medicaid really is the reason for Black doctors to be able to practice in this country. So before Medicaid, most Black doctors had to kind of go in through the colored entrance of hospitals. They were assistants to white doctors. Many Black doctors were kind of bartering tomatoes and potatoes and cabbages for care because a lot of people couldn't afford care. What Medicaid did was it offered an ability for there to be funding, right? A source of payment for doctors. And so it was a real lifeline for Black doctors and has continued to be. What this means now is that because we're overrepresented in Medicaid, it's great. It means that we have insurance. But what it means now is we are overrepresented in Medicaid. We're also overrepresented in a low-wage health workforce. And so when you destabilize both at the same time, it's not just a healthcare issue, it's an economic justice issue. Medicaid is not just a health insurance plan, it's infrastructure. It holds up our entire community.
Yeah. And we keep hearing about work requirements and efficiency. What are those code words for? And what's missing from the conversation when we look at Black workers in home care and nursing and community health roles?
Yeah. So let's just step back a little bit and hear what these buzzwords actually mean. So, in July 4th, something passed called HR1, which some people know as the One Big Beautiful Bill. I continue to call it HR1. What that did was took $1 trillion cut to Medicaid as a program. Because Medicaid, you have to think of Medicaid as a state and federal partnership, right? That's why it has different names in different states, different services in different states. So each state has a different set of, there's kind of what I would call the federal floor and the state ceiling. So depending on where you live, you may have more services in Medicaid, but you'll never have less than what the federal floor is. So like everyone has a base Medicaid, right? And then some states have much better, service delivery than others. When we hear about these buzzwords like work requirements, you always have to certify to be on Medicaid, right? You turn in documents and that's how you're given your Medicaid card, or depending on, if you live in New York, you are on Medicaid, right? That is one of the 7 states that actually call it Medicaid. But if you're in Georgia, they call it, Peach program, Peach Health, and they call it something different in each state. So work requirements, and we've heard this before, and we heard this a lot in the previous Trump administration, is kind of individuals proving that they are working, or volunteering, or contributing so that they can get their healthcare coverage. This is kind of a weird misnomer. Let's remember that half of the people on Medicaid are children, right? They're under the age of 18. So those folks will not be able to, they're not going to need work requirements. But for the adults, work requirements are going to be a new program. That's not coming into play until 2027, but that is brand new. And we've never really seen that work well. A couple of states have tried it. We've had a lot of pilots and tests. We haven't seen it work that great. And most people already work that are on Medicaid. So, think of, unemployment, right? You tell people I'm looking for a job, and then you get your unemployment check. That we've never had to do to get your healthcare coverage. So that's a little bit of some newer blockades for you to get your care. Another thing is recertification. In the past, we've had to recertify for Medicaid every year. They call that redetermination. They call it these buzzwords. And so typically there are documents you need to turn in. They want to make sure, you're still income qualified. Now there are lots of different categories for how people qualify for Medicaid, right? You could be disabled, you can be genetically unlucky, you can be income qualified, and it changes by state. Some states have programs for individuals who have cancer. Some states have programs for individuals who are new entrepreneurs. Like every state has something a little bit different. But what will happen is now folks are having to recertify every 6 months. We've never done that in this country before, and we're not sure how that's exactly going to work either. So a lot of this is like experimentation, but it's experimenting with 80 million people's care, that's a bit scary.
Right. It's experimenting with their lives, right? And you may bring up so many different points. You can have, fatigue from having to re-register over and over again every 6 months. But also when you think about work requirements, we know that with Black people, there's a saying that we're the last one's hired, the first one's fired. So what do you do when we are losing jobs across the nation and they're tying that to your healthcare? So with everything happening right now, from elections, inflation, global crisis, this thing can sneak under the radar, but why should Black communities and other marginalized communities, for that matter, see Medicaid as a frontline civil rights issue in 2025?
Well, Medicaid's always been a frontline civil rights issue. I mean, I think healthcare has always been a right and a privilege. And in order for us to be economically a part of society, we have to be healthy, right? So that's one of the things I've always said is a part of justice. In order for us to be productive citizens, we have to be healthy so that we can contribute to society. I think you're absolutely correct when you talk about how stressful it is to be thinking about all of the hurdles that are going to happen for you to keep healthcare, not only for yourself, but for your children, for your ill parents, etc. It's a very stressful thing. So we're encouraging new determinants of health for the first time ever. We have this kind of new category, which is like political determinants of health, things we've never seen kind of before. The other thing I will say is that the quality and duration of life will be impacted, not just, and I think people will be delaying care. Some people won't even apply for Medicaid. They don't even want to be bothered with being told no, which we've already, experienced. That's a real travesty where people, are feeling like, I don't even want to partake in the system. As you know, we have a lot of individuals who are feeling that the government is tracking them, or there's, fear of immigration, or all of these other issues that are, wildly a part of the fear mongering that's happening. So when we talk about Black folks and Medicaid, most of us work. We've known this, but we may not have like these traditional 9-to-5 jobs, right? We are home health aides. A lot of us do a lot of unpaid caregiving. Mm-hmm. Is that going to count? Right? We're childcare workers. We're gig workers. We've been helping, Mrs. Jones down the hall. We drive the church van and get seniors, out of their homes. This isn't about laziness, right? It's about wages and support. So I think you have to kind of dismantle this myth that people on Medicaid don't work. Many of them work, and they actually work many jobs. They just cannot sustain a living wage, even with multiple jobs.
Right. And with this being the frontline civil rights issue of 2026, if there is a cut, right, if Medicaid is cut even further or weakened even more than what we're seeing now, what does that mean in terms of Black health outcomes, Black wealth, right? Black workforce stability over the next decade? What happens if Medicaid is allowed to fail?
Well, unfortunately, Medicaid is failing a little bit. It's getting gutted. I mean, $1 trillion being taken from a system is a lot. And, who is going to fill the gap? It's not going to be philanthropy. There's not going to be, a ferry with money that's coming to fill that gap. And it's not going to be quick. It's not like we get this administration out and, 3 more years and we can go back. I mean, think of how many lives will be lost in 3 years. It means a lot for our health, for the Black Wealth Index. It means a lot for jobs and workforce stability. You talked earlier about, if you look at the unemployment rate in the Black community, it has skyrocketed to lengths that we have not really seen before. So it means more debt. It means more burnout. It means more people dying younger. It means more stress. It means fewer people left to get care. So Medicaid is not a handout. I think that there's a real misnomer. It is an insurance program. Just like everybody else gets insurance through their job, it's an insurance program. But Medicaid is also just a foundation. If you pull that out from underneath a society, the whole structure fails. And unfortunately, I think we're going to, this is a really unfortunate experiment that is happening with elections and inflation and kind of global chaos all happening at the same time. This is really about, people often ask, what is a solution? What do we do? And I think there's lots of things we can do. We can bound in our communities together. Our churches can start putting gyms in churches, and we can start to figure out how do we keep ourselves healthier? How do we grow some food? And I mean, we can start to come back to some of our community roots and start to take care of ourselves. And I think that's what we're going to have to learn how to do as we start to work ourselves through this. I think our Black-led and Black-run CBOs are going to really have to figure out novel and creative solutions to help with this, unique and creative ways that we can help with the work restrictions. And I think we're going to have to advocate. We're going to have to really fight for our lives. And I think that that's a level of fight that we haven't seen probably since 1965.
Right. And it's one of those things, every generation we have a different fight to give, right? But I want to bring in Dr. Roger A. Mitchell. He's the president of National Medical Association to talk about how this is impacting the workforce. So welcome, Dr. Mitchell.
It's good to be here. Good to see you, Doc.
Yeah. We just talked about Medicaid and how it serves nearly 1 in 4 Americans. I mean, this is a huge program. But what is this impact on the Black physicians and the sustainability of practicing medicine, particularly in those underserved communities out in the rural areas, as I'm clearly from? How would what impact will we see kind of immediately based on these changes?
Well, you said it. I mean, Black physicians tend to take care of Black patients. We tend to take care of Black patients in a way that others may not take care of those patients, whether it's in rural communities or urban communities. And as has been said, disproportionately, we're on Medicaid. So Medicaid, we know that there are, like you said, 1 in 4 individuals there on Medicaid. And our physicians are impacted because if you remove Medicaid, if you remove this safety net, it destabilizes the whole system. It creates an environment where there's less patients that can pay for their care and more unsubsidized patients. So what does that mean? It doesn't mean that patients that need care won't attempt to get care. Most individuals, if they're sick, they're going to seek care. They may not seek care in the clinic where they used to. They may not have a primary care provider, so they go to the emergency department. And if they do go see to the clinic, particularly federally qualified healthcare systems, then there may be an opportunity for them to get care, but that care is going to be unsubsidized, meaning it's going to be care that has to be given for free. And so anytime the care is given for free, then that margin for organizations and physicians, hospitals that are safety nets, and physicians that take care of these patients, those thin margins create an environment where they might not be able to pay for a staff member. They might not be able to pay for a particular test that they need to provide. So those razor thin margins create an environment where care delivery is compromised because the care is unsubsidized. And so this is a big issue. It's a big concern for the National Medical Association and for our members, because our members take care of communities that are getting their care through Medicaid.
Yeah. And we over the years, we've been seeing this kind of exodus, right, of doctors, Black doctors, having to leave these rural and the low income areas. And what happens in that void? Can you talk to us about the importance of the hospital deserts and what is being left behind with these policy changes, particularly as it pertains to Medicaid?
Well, you said it, right? There are hospitals that are closing in our rural communities. There are doctors that are saying, "Hey, listen, I can't afford to be in practice that's heavily subsidized by Medicaid because I can't give the care that I want to give." And that's extremely important, because these are communities, and not just Black communities, but these are poor rural white communities. These are poor urban Black, white, and Hispanic communities where the commercial insurance is not able to subsidize the Medicaid. So let me say it this way. Medicaid already does not provide 100% of the cost of care. It provides anywhere from 30 cents to 40 cents on the dollar. Commercial insurance gives maybe $1.20 on the dollar. And so oftentimes those of us that treat patients that are largely Medicaid or have a Medicaid population are able to subsidize the care for those that are on Medicaid with those that have commercial insurance. So that mixed type of insurance by our patients is important to us. When you start pulling individuals out of Medicaid and now they're uninsured, they're going to continue to seek care. And that is unsustainable in a business model for physicians that have to keep the lights on, have to employ nurses, have to employ techs, have to pay the premiums on their equipment. These are the types of things that puts physicians out of business in areas where physicians are needed the most and in an environment where there's a shortage of physicians in this country. We should be doing the opposite. We should be investing in our communities. The HR1 was never a healthcare bill. It was a tax bill. It was a spending bill. It was a bill that they said they had to cut dollars. And because healthcare is the largest spend in this country, obviously was on the chopping block. But if we really wanted to reform healthcare, we would take the time to actually look at healthcare. We are moving down that road in value-based care, making sure that we prioritize prevention, that we prioritize and give increased incentives for screenings and catching disease processes early in the disease continuum, particularly chronic diseases like diabetes and hypertension, but also cancer screenings and making sure that we're catching and ensuring that there's regular cancer screenings. Value-based care really was the road towards decreasing the cost of care in this country, because we know that healthy individuals cost less than sick individuals. Right. But this bill is not doing that. It's really just cutting the process at the knees.
Right. It sounds like it's doing actually the opposite of that. And we talk about there's 1 in every 4 Americans that's on Medicaid, right? So oftentimes it has to impact you. It has to land on your doorstep for it to have a driving force for you to care about an issue. So how do we talk to those 3 out of 4 who have commercial insurance, or those persons that's not on Medicaid? How would these changes now impact them, their access, their cost of medicine, their health outcomes?
Well, the 1 out of 3 may have a disabled child, right? And that disabled child is getting their support through Medicaid. They may have an elderly individual that is dual eligible. They're not really bringing in any dollars, and they're over 60 years old. So they're getting Medicare and Medicaid, and that Medicare is paying for their prescriptions. Invariably, we have someone in our family that's getting Medicaid. And see, this is the calm before the storm, Doc. This is a calm before the storm, because people aren't really anticipating the impact that it's really going to have. Some people are starting to feel it because the subsidies are not kicking in yet, and individuals' premiums that are paying on the exchange is going up, and we're seeing it there. But when those individuals start being pulled off the rolls, and individuals that used to be able to get regular care now don't qualify, and when individuals are pulled off the rolls because of the bureaucracy of the things like work requirements or recertification every 6 months, when those individuals get purged and then show up to their doctor's office, they're going to say, what happened? I should be getting this. They're going to be calling their senators and Congress people. They're going to be calling the family members that are the 3 out of the 4, right? They're going to be calling family members and say, listen, I just got kicked off of my Medicaid and I'm fully qualified. There will be individuals that are kicked off of Medicaid that are fully qualified and then are caught in the bureaucracy of recertification. That's actually built in the calculus of the savings that is being suggested by the HR1. And so it's really going to be devastating. And as a forensic pathologist, I often say that I find failed policy on my autopsy table because individuals are going to die because of their lack of access. And then they're not going to want to go when their disease or injury is preventable or treatable at a lower stage. They're going to be accessing things when the disease is further along.
You know, you brought up such great points, how this is impacting patients, how this is impacting the workforce as far as the Black doctors. You know, one of the other things I think about is what are those doctors who are coming up the pipeline, right? Our medical students. With medical school debt climbing, how does Medicaid reimbursement rates and the safety net network factors that play into this pipeline, how does it impact that for them? Are we going to have future Black doctors? Are people going to say, hey, it's not worth the climb when I get there, I can't actually do the work?
Well, Medicaid is one of the issues, right? It is a big issue. Medicaid, particularly in safety net hospitals. I used to be the president of Howard University Hospital, safety net teaching hospital, one of the most historic Black teaching hospitals in this country. And because we were over 80% Medicaid, that those dollars coming in paid the doctors, but also paid an environment where we could teach those residents and teach those students. When you start bringing the Medicaid, the actual subsidized amount of patients away from that hospital, then the amount that the hospital can spend on things outside of care that lead to higher quality care, that stuff starts going down. The clinics that we send our residents and medical students to, often in urban centers, rural centers that high Medicaid population, we send them there to be trained on patients that often have Medicaid. And so if those patients are either not coming or not paying for their visit, then the likelihood that we're going to be able to train individuals at the higher rate goes down. But also in this HR 1 bill is this cap on graduate loans, graduate school loans, which affects the medical community. Because if you cap our loans at $200,000 over the period of time that you could take loans, there are individuals that can't afford to go to medical school without loans. We're talking about loans, things that can be paid back over time, low interest loans, because this country at one point thought it was important for there to be diverse classes and diverse groups from socioeconomic, right? Not just Black people or poor, but socioeconomic conditions, as well as race, gender, creed, religion, and sexual orientation to be in the medical profession. Well, with these caps on these loans, it also limits those individuals that can even get a medical education to those that can afford it. I'll say it like this as well. So this Medicaid is the issue. Yes, it's going to decrease the amount of dollars that is going to be available for our training of our trainees as residents and medical students. This cap on funding for loans for medical school. But also the restriction has been removed by the LCME that required for retention and recruitment diverse classes. So now the medical schools in this country no longer are required to have diverse classes. I went to medical school in Newark, New Jersey, and my Jewish friend that sat next to me, my Italian friend that sat next to me, my Greek friend, my Indian friend, my Asian friend, we all brought a different cultural perspective to how we were learning the medicine. And I have taken that along with what I learned in the science and clinical aspect of my work. I've taken that cultural aspect and feel like a better rounded physician because of that. And I'm sure you had that same experience. So what we're seeing today is really an upheaval of the entire medical practice, and it's going to affect Black and brown people the most.
Yeah, and it's one of those unfortunate things. What we know is that representation matters. We know that outcomes are literally better, whether that's surgical or medical outcomes, when it comes down to race concordance and situational cultural concordance. So, I just want to thank you, Dr. Roger Mitchell and Adamika Meadows Arthur, for this important dialogue. I'm sure people now know that calling their representatives and seeing how we can start to try to right this correction is going to be paramount moving forward in the future.